Okay, I have been doing these epilepsy presentations for almost 20 years now. My daughter was diagnosed with epilepsy in 1992. She was very difficult to diagnose. Her father is a physician, and we missed the diagnosis for 2 years. And I became convinced that epilepsy education was much needed. We are going to get started right away, and I'll tell you more of my daughter's story as we go along. So we've got, right up here, we've got myths about epilepsy. And I have met people who believed each and every one of these things. So we're going to push them out right now. The tongue cannot be swallowed during a seizure. Absolutely not. You should never put anything in the mouth of a person having a seizure. There's one exception, and we'll get to that later. Epilepsy is not contagious. It's just like a broken arm. You can't catch it. It can start at any age. Fetuses in the womb can have seizures, and people can develop epilepsy right up to the day they die. Seizures, for the most part, are not medical emergencies. If you know that the child has epilepsy, the seizure is probably not a medical emergency. Most seizures in epilepsy are not convulsions. A lot of people think that epilepsy is a convulsion. Most seizures are not convulsive. Children can and do outgrow their seizures, which is a great reason why we should be getting them diagnosed and treated. If they get diagnosed early and treatment is able to control those seizures, and their EEG is normal between seizures, and their MRI is normal, they don't have any brain deformities, 70% of those kids will outgrow their seizures. Why would you not want to get them identified and treated? Medication does not stop all seizures. About 30% of people with epilepsy continue to have seizures despite trying every known medication for epilepsy. People with epilepsy are not necessarily mentally ill or developmentally delayed. However, about a third of the kids who have developmental delays, they also have epilepsy because they have some underlying problem with their brain. And likewise, people with epilepsy do tend to have a higher incidence of depression. Having epilepsy is depressing, and some of the medications, when they slow their brains down to stop the seizures, they also cause depression. So what is epilepsy? Epilepsy is recurrent seizures, 2 or more seizures that are not provoked. Who knows what a provoked seizure, what might provoke a seizure? Anybody? A strobe light, well, yeah, in some people, a strobe light will provoke a seizure. Heat, yes. Being overheated. Stress, yes. Fever. In kids, it's a number one reason for a provoked seizure is a fever. In kids with diabetes, having a high insulin level, that's a provoked seizure. When they're provoked by another medical condition, it is not epilepsy. 1 out of 10 people will have a seizure in their lifetime, but it is not epilepsy until there are 2 or more seizures that are unprovoked. Yes, back there.
Sometimes when your sodium levels are off, it can provoke a seizure.
Yes, having your sodium levels off can provoke seizures. Our brains function because the neurons communicate with each other by electricity. We have sodium and calcium ion channels in our neurons, and when those get out of balance, that causes seizures. And some people have genetic defects in those sodium and calcium ion channels that will cause them to have epilepsy. So, sometimes you hear the term seizure disorder, and in fact, I've had people come up to me when I'm doing displays at the state fair or at health fairs, and they'll say, I don't need to talk to you. I don't have epilepsy, I have a seizure disorder. Well, guess what, folks? Most seizure disorders are epilepsy. There is a very small percentage that is something called psychogenic non-epileptic seizures. PNES, it's up there. And those are seizures. They are convulsions which are occurring for psychological reasons because of some extreme trauma in that person's life. That is a seizure disorder that is not epilepsy. But everything else termed seizure disorder is epilepsy. So most people who are diagnosed as having a seizure disorder really have epilepsy. It's just that the doctors and the families don't like the term epilepsy. They're afraid to use it. They stay away from it. And then the families end up not getting the information that they need because they don't realize that what is really going on is epilepsy. Comes from a Greek word, and I took the trouble of getting that Greek word up there for you. It means taken over from forces outside of yourself. So, we talked a little bit about what a seizure is. When those neurons have excessive disorderly discharge, that's a seizure. Our brain, they have systems to make the neurons fire and then suppress the firing. And when those systems get out of whack and the brain is firing uncontrollably, that is epilepsy. That's a seizure. What the seizures look like and what the person having them feels depends on where in the brain and how much of the brain is involved. And this is a really important point. And it's the reason my daughter was misdiagnosed for 2 years. Epilepsy is very common. It's extremely common. It's more common than breast cancer. And the Institute of Medicine's report, which came out in March of 2012, estimates that 1 out of every 26 Americans will have epilepsy during their lifetime. 1 out of 26. That means that some of us in this room had epilepsy as a kid or will develop it before we die. So what's the rate for epilepsy at school? Well, 1 out of 50 people under the age of 18, and in each of your school buses, potentially 1 student would have epilepsy. And as I said before, kids with developmental disabilities are more likely, about 1/3 of those kids also have epilepsy. So if you're driving a special ed bus, you've most likely got a kid with epilepsy on that bus. So what do? How can you help these kids? First of all, you want to be a good driver. And if you have to deal with a seizure emergency, you want to pull the bus over. Seizures are very disconcerting. It's easy to get emotional when you're dealing with a child having a seizure. It's hard to watch. And as a parent, I will never forget the first convulsive seizure that my daughter had. It was absolutely traumatic to watch. You need to stay calm. And providing you with the information that we are providing today is going to help you know what to do so that you can stay calm. You want to be supportive of the child, and you want to encourage their peers to interact positively with them despite the epilepsy. You want to be familiar with the child's seizure action plan. And every child with epilepsy should have a seizure action plan on file with the school. And if you're transporting them, it would be really helpful if the school nurses or the school staff would share those seizure action plans with you. And what to do for a seizure on the bus should be a part of that seizure action plan. And if it's not, if I were driving that bus, I'd give it back to them and say, What's the plan on the bus? The parents help develop the seizure action plan, and the child's physician signs off on it. And you need that so that you know what to do. Every case of epilepsy is unique because our brains are unique, and whatever it is that's causing the seizure disorder in that child is unique to that child. So there are no hard and fast rules for what the seizures are going to look like, what the child is going to experience. It is individual to that child, and every seizure action plan should be individualized to that child. Special issues. Is the child in a wheelchair? We have a special sheet on wheelchair first aid, and it's part of your laminated handout. How are you going to handle it with dispatch? What are you supposed to do? Have a plan beforehand. How are you going to keep the other kids calm and safe? Does the student use rescue medication? This is Diastat. It is a rectal rescue medication which will stop a prolonged seizure state. You need to know if the child uses this and if you're likely to have to use it on the bus, and can you be delegated that responsibility? No, not in Bellevue, okay. So if the child needs this, what's going to happen? What are you going to do? How are you going to get the child to the medication or the medication to the child? Does the child use the vagus nerve stimulator? This is an implantable device. It's in the chest. I would guess that you can use the magnet to set off the vagus nerve stimulator.
I don't know that we know of any children who have that, but I'm sure there are some.
We'll get to how it works in a little bit, but that's something that you should know if the child has epilepsy. All right, special challenges as school bus drivers. Sometimes it's really helpful if you can communicate with the parents, but sometimes the parents don't speak your language or you don't speak their language. Sometimes the parents are in denial about the epilepsy. They are unwilling to talk about it. They do not want their kid to have epilepsy, and they will not talk about it. Some of the students are medically fragile. You really need to have a seizure action plan for them. You need to not drop off a kid and leave them by themselves if they've had a seizure. Kids who've had seizures can be confused, very sleepy. They are not functioning normally, and you must not just drop them and leave them. They need to be in the care of a responsible adult. A huge problem for kids with epilepsy is bullying. If a kid has a seizure on your bus, you can do a lot to set the tone and the acceptance of the child with epilepsy and help the other kids not to be afraid. This is Dr. Vining. She's a pediatric neurologist at Johns Hopkins, and she and I worked together on a program back in the 1990s in Oklahoma. And I can still hear her saying, anything your brain can do, anything at all, it can do abnormally as a seizure. Seizures can be so many different things. And we're going to spend a little bit of time on that in just a while. Seizures can look like fainting. They can seem like migraines. I worked with a neurologist who would put kids in the hospital for 24-hour EEG video monitoring. He would think that they had epilepsy. It would turn out they had migraines, and likewise, they would have what he thought were migraines. He'd put them in for the monitoring, and it would turn out that it was truly epilepsy. So they're very easily mistaken for one another. Even neurologists cannot tell the difference from the symptoms. They have to have that EEG. Seizures can look like behavior disorders. They can look like ADHD. Sleep disorders. Tourette's, panic attacks. Our Lincoln support group leader was misdiagnosed for 3 years as having panic attacks, and what they really were seizures. And she went to the emergency room in Lincoln so many times, she doesn't even know how many times she went. They finally got it diagnosed and properly treated. Movement disorders. Yes?
What's Tourette's?
Tourette's. It's a brain disorder where you will have movements that you cannot stop, or you will shout out words that are inappropriate at inappropriate moments. It's like a tic disorder. I think they also call it a tic disorder. And you'll either shout out words or do some sort of repetitive movement. And both of those things can also be epilepsy. People can repeat words or phrases, or they can have muscle seizures in one muscle or groups of muscles. And we're going to get to all that. So what are you looking for in kids? How would you help a kid get diagnosed and into treatment so that they might have that chance of outgrowing those seizures? Teachers are often the ones who say to the parents, you know, I think you should mention this to your child's doctor. You should take your child to the doctor. The teachers see these things. The parents don't know what's going on. My husband and I did not know what was happening to our daughter, even though my husband had been to medical school. Short attention blackouts. Sudden falls for no reason, excessive clumsiness. Brief periods where they're unresponsive or inappropriately responsive to you. Unusual sleepiness or grouchiness, difficulty being awakened. Frequent complaints that they see, hear, smell, taste, or feel something that's weird, not there, something unusual. And my daughter made up fairy tales about what was happening to her. She heard a man's voice. And she made up some pretty incredible stories to explain what was going on. Confusion or sleepiness following sudden stomach pain. Repeated unnatural movements that look strange. So previously, the terminology for seizures was grand mal and petit mal. We don't use this anymore. It's not relevant to how you're going to treat the seizures. And petit mal groups several different kinds of seizures together, which are totally different. Grand mal was convulsions, and petit mal was everything that wasn't a convulsion. We have better terminology now. The seizures are divided into partial seizures and whole brain seizures, or generalized seizures. The partial brain seizures are also called focal seizures because they focus on one specific part of the brain, wherever it might be for that child. They're focused on a part of the brain. Which one do you think is more common, partial or generalized? Partial, right, absolutely. Partial seizures are further subdivided into simple and complex, and we're going to go into these in just a second. So here's your graph, the pie chart. All of those are partial. Partial seizures are almost 2/3 of all seizures. If you add in the absence, which used to be included in petit mal, because they're not convulsive, they're just little staring spells, you do have 2/3, over 2/3 of seizures. The generalized tonic-clonic are less than 1/4. So less than 1/4 of people with epilepsy are having seizures that are convulsive. So what happens in a tonic-clonic seizure? They lose consciousness. This causes them to lose their balance and fall. The seizure starts with them stiffening up, and they may stiffen with their arms outstretched or down. All of the muscles in their body go stiff and rigid. Their diaphragm contracts as that happens, and there will sometimes be a sound, a call, a funny noise, a yell as the air is expelled from their lungs. What it sounds like is going to depend what they were doing with their vocal cords and how their throat is configured. They don't all sound the same. Their eyes may roll up or go to one side. Then they start into the clonic phase of the seizure. Clonic is jerking. So they come out of the stiffening phase and they go into the jerking phase. Extra saliva is produced during the seizure, and this causes the foaming at the mouth that we sometimes see. What's happening is they have clenched teeth, they've made extra saliva, and they're breathing through their clenched teeth, and it makes bubbles. It's air bubbles in saliva. That's all it is. It is not contagious. It is not dangerous. It's just air bubbles in saliva. Because of that extra saliva, they can choke on their saliva. So that's a concern. Their breathing may be shallow. They may not be breathing normally. And because of that, they may turn a grayish, bluish, greenish color around their mouth, and their nail beds may become blue, cyanotic. It is possible that they will vomit as part of the seizure because sometimes the muscles of the digestive tract are involved. That's also a concern. You do not want them breathing that vomit into their lungs. Most of them will not vomit, but some of them can vomit. They may lose bladder and bowel control if the muscles of their bladder and bowel are affected, particularly if they have a full bladder. This happened to my daughter on 2 occasions. Of all the seizures she had over the years, only twice did she wet her pants. It's extremely embarrassing for the students. One time my daughter did it in the morning as she was getting ready to go to school. No problem. It was her family. The other time she was at music camp, and that was pretty devastating. She was on her way to the bathroom, and she had a seizure walking to the bathroom, and she wet her pants. So it doesn't have to happen, but it can happen. And if it does happen, it is really helpful if you can explain to the other kids that it was out of the control of the student, it is not their fault, and it is nothing for them to be ashamed of because it is their medical condition. The duration of the tonic-clonic seizure is usually 2 to 4 minutes. The first aid says call for help after 5 minutes. Most seizures will not last that long. Afterwards, and this is where you don't want to leave them alone after they've had a seizure, they may be extremely sleepy or confused for up to as long as a couple hours. So you need to make sure that they're with a responsible adult after they've had the seizures. There may be teeth grinding, shallow breathing, and fluids from the mouth. This is the second kind of generalized seizure that you're likely to see in kids. This is a whole brain seizure, absence. They're very brief, 15 seconds or less, usually 1 to 10 seconds. Their eyes may blink, flutter, roll, and then they're right back with you. They're with you right up till the minute they have the seizure, and then as soon as it's over, they're right back with you. It looks like daydreaming, unresponsiveness, and you're going to see an example of it in the video we're going to watch. It is very hard to get diagnosed because they are so fleeting. Kids with this kind of seizure will often have hundreds of seizures during the day. Very difficult for their learning and for their behavior because they are missing little chunks of time all throughout the day. Partial seizures, the simple partial seizure. I told you there's 2 kinds, simple partial and complex partial. The difference between the 2 kinds is awareness. A simple partial seizure is a small enough focused area of the brain that they remain aware. They know that something weird is happening to them, but they are still aware. They know what's going on. And unless it's occurring in their language center, they're probably able to still talk to you normally about what's happening to them. There are 4 kinds of simple partial seizures. Motor, muscle seizures. Sensory, any of the 5 senses. Autonomic, any of the systems that we control automatically without thinking about them. Breathing, heart rate, skin color, whether we blush, goosebumps, blood pressure, the way the food, the peristalsis that moves the food through the digestive tract. All of those are things that our body does automatically, and they can be interfered with by seizure activity and occur abnormally. Psychic seizures are the last kind. These are emotional seizures, fear, foreboding, anger. This is why seizures can be mistaken for behavior problems. And they can be confused with acting out, mystical experiences, religious experiences, mental illness, and also with psychosomatic illness. Complex partial seizures. Okay, this is enough of the brain. It's not all of the brain, but it's enough of the brain that they don't know what's going on around them. And they can be walking around and saying things, and they have no clue what they're saying, where they're going, what they're doing. My daughter's worst fear was that she would be injuring herself, and she did not respond to pain stimuli. That's how disconnected she was. She liked to cook, and she was afraid that she would burn herself or set herself on fire if she had a seizure while she was cooking, because she did not respond appropriately to pain stimuli. They can be walking around. They don't know what they're doing. If they're doing that, you want to keep them from getting into danger without grabbing them. If you grab them, they will fight with you. They will strike out. They don't know why you're grabbing them. You put yourself between them and danger and keep them safe. It can look like drunkenness or drug abuse, or it can also look like aggression or disobedience, bad behavior. These seizures usually last 1 to 3 minutes. That's a long time to be walking around not knowing what you're doing. Yes, question?
In that condition, would they respond to a verbal command or request of the driver?
Would they respond to a verbal command or request from the school bus driver? No. They will not understand what you're saying to them, and they will not respond appropriately. They might briefly turn their head toward you, and I experienced that with my daughter. If you said something to her, she might very briefly look at you, but then very quickly she would fade off and her eyes would become unfocused. She would not register whatever it was, and they will not remember it either. They will have no memory, and they will not respond appropriately. So we're going to go into a little bit of these systems, but I'd like to show the video now before we do this. Can you help me, Rich, to switch to the video? Do I have any questions while he's doing that? Yes?
Boy, this reminds me of Alzheimer's.
This reminds me of Alzheimer's, he says. Yes, well, and in fact, 5% of Alzheimer's patients also develop epilepsy because of the damage that's going on in their brain causing the Alzheimer's. And in the elderly, epilepsy is frequently not diagnosed because the doctors are confused by the symptoms and think that they are having Alzheimer's, memory decline, or they're having Parkinson's because of the shaking. Senior citizens should get EEGs to rule epilepsy out, and people with Alzheimer's can have epilepsy and Alzheimer's, and I read a paper just yesterday about epilepsy and Alzheimer's. Having epilepsy when you have Alzheimer's causes the decline to be faster and more devastating. So Alzheimer's patients should be tested.
We know that at any moment he could have a seizure. You know, you don't know when it's going to happen.
If I don't take the medicine, I have a seizure.
I picked him up and I'm like, no, what's wrong? And next thing I know, eyes roll in the back of the head and he just collapses in my arms and he starts shaking.
The fear of leaving the house and going over to a friend's house was kind of fearful for me because I was afraid, you know, when would it happen, where would it happen again?
But I ended up having a seizure in the hallway. And it was bad because then classes changed and everyone saw me having a seizure.
We didn't really know what the procedure was. We just tried to take care of the student that fell.
It's an awful feeling. It feels like someone just beat you over the head with a brick.
Living with epilepsy is impossible to describe. In some ways, it's like living with heart disease or diabetes or asthma.
It's another thing to think about something going wrong with the brain. There is such a mythology still associated, I think, with epilepsy. A stigma, if you would, associated with epilepsy, that you've lost control over what makes you that unique human individual.
So you can pull yourself up. Nowadays, I think it's becoming more common and wide known that it's a condition that can be controlled, and you know, heart disease is treated with a certain medication, you know, diabetes is treated with medication. Well, epilepsy is treated with medication. It's just in your brain as opposed to in your heart or, you know, in your bloodstream.
It's not mental illness. It's a physical ailment. Your brain isn't working right, just like your lungs don't work right with asthma.
There are more than 50 million people living with epilepsy worldwide, nearly 3 million in the U.S. In fact, 1 out of 10 people will have a seizure at some point in their life. 70% have no known cause, 30% do. People with epilepsy are in every walk of life. They cross your path every day. And for most people with epilepsy, the fact that they live with this condition is of little consequence.
99.9% of the time, your brain's fine. There's nothing wrong, okay? You can do anything you want to do.
But when a person with epilepsy does have a seizure, that's the time when others can help. This video will explain epilepsy and what you can do to assist a person having a seizure.
Some people call epilepsy or seizures a brainstorm, a storm in the brain. But what does that mean? Well, it means that this normal activity where the cells are signaling from one to the next is basically doing it in an uncontrolled way. So it keeps going and going and going. Depending where in the brain that activity happens, your seizure looks different. It could be a repetitive thought, it could be a vision, it could be a smell.
It can also be the classic thing that people tend to think of when they're thinking of seizures, and that's the tonic-clonic seizure, or what we used to call the grand mal. It can also be, on the other side of the coin, what we used to call petit mal, where all we're seeing is an absence of a person. They just go blank for a moment, stare off, maybe a little bit of movement. And so we have the huge range from the biggest, the strongest, the most worrisome for most people, the grand mal or the tonic-clonic, all the way down to a little bit of movement or simply staring.
Epilepsy is defined as recurring, unprovoked seizures. Seizures are caused by abnormal electrical discharges in the brain and are classified as either generalized or partial. Generalized seizures, such as tonic-clonic, are the result of abnormal electrical activity affecting the entire brain. Most of these seizures are obvious: a rapid loss of consciousness, falling to the ground, full body convulsions. Partial seizures, however, are more difficult to recognize. These seizures affect only part of the brain, and the symptoms depend on which area of the brain is affected. Simple partial seizures can cause a change in sensation or uncontrolled muscle movement, like twitching. Complex partial seizures result in a total loss of awareness, though the person actually remains conscious. They may stare, repeat physical motions, or act disturbed. Complex partial seizures can be difficult to recognize and can easily be confused with drug or alcohol abuse. How can a bystander help? First, let's look at the tonic-clonic seizure, where a person is unconscious and convulsing.
And so the first thing is that if someone is falling, to try to at least ease them down to the ground. If there's a small chance that the person may actually have a lot of drooling or may vomit, and so to put them on their side, and so that the liquid coming out of their mouth goes out of their mouth, drains, and doesn't go into their lungs, which would create another problem. It's important not to put anything in the patient's mouth, because of one of two things will happen. Either the person who is trying to put something in the patient's mouth is going to become injured, or similarly, if something such as a spoon or a pencil is put in the patient's mouth, it could potentially chip the patient's tooth or cause another type of an injury, and that also could potentially be swallowed, the object that's bitten off. If the patient is wearing something that's tight-fitting around their neck to try to loosen it, similarly, if the patient is near something dangerous, it's important either to move that dangerous object away or to move the patient into a safer place while this is happening.
And allow it to run its course. There is nothing that a person can do to change the course of that seizure.
A tonic-clonic seizure is usually not dangerous to the individual. However, in some situations, emergency medical services should be called so that the person can be assessed by professionals. Call 911 if any of these conditions apply. This is a first-time seizure. The person is injured or has badly bumped his or her head. The seizure happened in water. The convulsive portion of the seizure lasts longer than 5 minutes. A second seizure begins shortly after the first concludes. The person does not regain consciousness within 5 to 10 minutes, or the person has diabetes or is pregnant. On the other hand, calling EMS may not be necessary if the seizure lasted less than 5 minutes. You know the person has epilepsy, you know that this type of seizure is routine for them, and the person has suffered no injuries. How do you tell if a person has epilepsy if you don't personally know him or her? Oftentimes, the person may be wearing a bracelet, necklace, or watch that indicates the diagnosis.
When you know that someone has a seizure disorder and someone has a seizure in your presence, whether it's a generalized tonic-clonic seizure or a different type of a seizure, generally speaking, you do not need to call 911 or rescue services unless the seizure is going on for more than 5 minutes.
When calculating the 5 minutes, keep in mind there is always a period following the convulsion where the person is unconscious or extremely groggy. This is known as the postictal stage, and this time period is not included in the 5-minute calculation.
You may see somebody being very sleepy, really poorly, slowly responsive, and that would be described as the postictal stage. This seizure is over, and that's an important thing for people to understand, because the postictal period may go on for quite some time, for many minutes, even 15 minutes, 30 minutes, and in that time frame, that's not the seizure. So that doesn't mean, hello, the seizure is going on and you need to call medical services. You need to be there reorienting the individual, calming them, saying you know what happened and that they're going to be right back up and doing things shortly.
It's not something people need to freak out about, because chances are that person's had a lot of seizures before and they've bounced back every time.
Another common form of seizure, and one that is not nearly as obvious, is the complex partial seizure. Because only a small part of the brain is affected, a person may still be able to perform gross motor skills, like walking or sitting upright, yet be totally unaware of his or her actions.
There's no awareness at all. So, I'm a 30-year military veteran, so I'm used to responding to instructions. But once in a seizure, I don't hear you.
They may stare, mumble, repeat phrases, blink excessively, smack their lips, or pick at their clothing. However, they will be totally unresponsive to instructions because their consciousness is severely impaired.
In the situation of complex partial seizures, this is one of the times when people really frequently don't even know it's a seizure. And somebody might be staring and
Kevin, can you hear me? Can you hear me?
but somebody might say, I was looking at you and you looked like you were spaced out. Are you on drugs? You know, that's the first question. Are you drunk? Are you on drugs?
And their consciousness is impaired. It's not lost, but they're clearly not processing language, and they're not processing your intention.
But a perception of being threatened will lead to somebody pushing away, hitting, fending off what, at least momentarily, as a reaction, is thought of a threatening move.
So that what you want to do is take harm out of their way, close the door. They will take the path of least resistance. So that I think the most that you would want to do is guide. You don't want to restrict them. You don't want to force them to sit down. That is the last thing you want to do.
A complex partial seizure can last from 1 to 5 minutes. When it's over, the person may be tired or may recover immediately. Emergency medical services do not need to be called if a person who is diagnosed with epilepsy experiences a complex partial seizure, unless they're not fully recovered within 30 minutes. There are 2 additional forms of seizures a bystander might witness: simple partial and absence. When a person has a simple partial seizure, consciousness is not affected because the abnormal brain activity is occurring only in an area that controls motor functions.
My arm is jerking. I can't stop it. It's not in my control. Brain that corresponds to that, the opposite side of the brain, and the motor area of the brain is making this happen, but it's uncontrolled, and that's a seizure.
Absent seizures, on the other hand, do affect consciousness and can easily be misinterpreted as daydreaming or ADHD in kids.
Were they just blank staring spells? Maybe, with some eye blinks. But again, this little thing. The complex partial, there's more confusion after it. The absence, right back.
When a person has an absent seizure, it's like a switch going on and off, okay? They're with you one moment, they're gone for a few seconds, and they're right back with you, picking up right where they left off.
No special action is required if a person who is diagnosed with epilepsy experiences a simple partial or absent seizure. What can trigger a seizure? In people who are diagnosed with epilepsy, common triggers include interruption of anti-seizure medication, stress, hunger, sleep deprivation, and flashing lights. For people who are not diagnosed with epilepsy, there are many things that can trigger a seizure. In the case of a first-time seizure, always call 911. So epilepsy can come in many forms. On one end of the spectrum are extremely brief absent seizures that may occur multiple times a day. On the other end of the spectrum, tonic-clonic seizures that may occur only rarely, but when they do can be quite disabling for the individual.
And epilepsy is not, it doesn't define us, and it doesn't stop us from doing anything.
A couple friends asked me if I wanted to go hiking 5 miles up 3,200 feet, and I was like, sure, why not?
Epilepsy, schmepilepsy. That's the way you should look at it.
I am not different than any other kid.
Don't have to treat them any differently. That's the main thing. You need to treat the person as any other person.
Don't start treating me differently. I'm just the same person with a minor addition.
For more information on seizure recognition, treatment, and epilepsy, visit epilepsyfoundation.org or call 1-800-332-1000.
All right, so we're going to talk a little bit more in depth about the partial seizures because they are the most common seizures. So they can be muscle, and a person in the film talked about the muscle seizures. They can be groups of muscles, single muscles, or all the muscles all at once. And the muscles can jerk, they can stiffen, or you can have a loss of muscle tone, a complete loss of muscle tone. And there is a kind of seizure, a whole brain seizure, where all of your muscles go limp. That's called an atonic seizure. And what happens when that kind of seizure occurs, because our heads are so heavy, the person having an atonic seizure will fall headfirst to the ground. They're very dramatic, and they can very easily cause further brain damage. These kids will often be wearing helmets to protect their heads when they have these drop attacks. They're also called drop attacks. So complete loss of tone is one of the things that can happen to the muscles. Sensory seizures. This is why my daughter got misdiagnosed. She heard that male voice, and she also saw colored lights radiating out of things. So she had visual and auditory seizures. On one occasion, she also smelled a really bad smell. Now, some people have an aura before a bigger seizure, before the tonic-clonic seizure. What is that aura? It's a simple partial seizure. Their seizures are starting in a very focused area of the brain, but then they're going on to spread. An aura is a simple partial seizure. And that is a clue to the physician which treatments may work better. Because the treatments that work for a seizure that starts in one little area of the brain are sometimes different than the treatments that work on a seizure that starts in the whole brain all at once. So these kind of observations can help the treating physician. You can have seizures of any of the 5 senses. In fact, the word aura comes from the Greek word for a wind on your skin. So the sensation of something on your skin that's not there, that can be a simple partial seizure. The autonomic seizures, we mentioned these before: heart rate, breathing, skin, temperature, sweating, flushing, goosebumps, pupil dilation. The first time I realized my daughter actually had a medical problem, she was being treated by a psychiatrist at that point. She had a seizure, a complex partial seizure, and when she was coming out of it, she said, "Mom, it just happened." I looked at her. We were in a dark room. I was trying to keep the sun out because it was a hot day. And her pupils were shut tight, really small, as if we were out in the bright sunlight. It was very inappropriate for the condition we were in. Her color was changed. Her pupils were not right. I realized at that point she had a medical problem, not a psychiatric problem. You can have the digestive tract, and when they're having the seizure, they can vomit, or they can lose bowel control, or you can hear noises coming from the digestive tract, or they may fart or burp because of the peristalsis movement happening abnormally as a seizure. Psychic seizures, these are the emotional seizures: fear, foreboding, anger. You can have seizures that are laughter or seizures that are crying. There's a really interesting ABC Nightline presentation on laughing seizures, gelastic epilepsy. A little boy, he had these seizures all his life. His parents thought he was very happy-go-lucky. He just laughed a lot. When he got to be 9 years old and he was laughing at school at inappropriate moments, they took him to the doctor. It turned out he had a tumor, and he was cured with surgery. But he went 9 years having seizures before they realized what was going on. So seizures can be laughing, seizures can be crying, suddenly, out of the blue, for no good reason. You can have memory problems that are seizures. You can walk into your own home and feel like you've never ever been there before. He says he does that all the time. Or you can encounter a situation or a person that you've never run into before, and yet you have the feeling, I've been here before, I've done this before, I've met them before. These are jamais vu is I've never seen it before. Déjà vu is I've been here before. Or you can have a complete loss of memory. Language. You can have trouble finding the words you need to say, or a complete loss of your ability to speak. By the way, on the sensory seizures, you can go blind temporarily as a seizure. So, in kids, when you have these psychic seizures, they can be mistaken for behavior problems. How do you know? Is it a seizure or is it a behavior? And it's not easy. It's not at all easy. However, here's some clues. Seizures in that person, in that individual, the seizure will happen in the same way every time. Whatever it is in their brain, whatever part of their brain is damaged or misfunctioning, is going to cause the seizure to happen in the same sequence every time. Now, in my daughter's case, her seizures came from the right side of her brain. Our right side controls the left side of our body. She would often pull up her left arm and clench her left hand. She would turn her head to the left. If the seizure progressed even further, her left leg might get involved and stiffen or jerk. But it was in that order every time. Her arm, her head, and then if it went on, her leg. Each patient is individual. The sequence will be their own, but it should be the same every time. Seizures come out of the blue. They're paroxysmal. They happen suddenly, unexpectedly, for seemingly no reason whatsoever. Behaviors, on the other hand, usually if you look at it carefully, you can find something that provoked it. Seizures are not changed by behavior modification techniques. Nothing will change them. They have to run their course. Whereas behaviors, you can alter them by an intervention. So, you have the first aid, you had it in the film, you have it in your handout, and I'm just going to go through it really quickly unless we have questions about the first aid. The most important thing is to stay calm, protect the person from further injury, and protect their breathing. You want to time and observe so that you can appropriately report. It really helps the treating physician to have accurate reports of the seizure. The Epilepsy Foundation have forms which walk you through what to look for. I know the first time my daughter had the grand mal seizure, I was so upset I wasn't able to observe anything or do anything calmly because it was very, very disturbing. The forms help you to stay focused, to observe. It also helps if you have other people, if you have an aide on the bus, or if you have kids who are old enough to tell time, assign somebody the task of timing the seizure and calling out every time a minute goes by. That way you worry about the health of the student and somebody else is worrying about the time. And if they're calling out, it's been 1 minute, it's been 2 minutes, it's been 3, then you know when you're getting close to, I need to call for help. You want to document and report seizures. It helps the patient to get control. It helps the treating physician. You want to pull over, stop the bus, protect the student from further injury, time the seizure, speak softly and calmly, don't grab or hold them, and follow whatever emergency protocol is in their seizure action plan. They can be very confused after a complex partial seizure, so you do want to make sure they're with a responsible adult. Tonic-clonic. Cushion and protect their head. You don't want them banging their head against a hard metal seat or the floor. Put a jacket under them, put your hands under them, whatever you can find that is softer than the hard object. You want to turn them on their side so that if they do have that extra saliva or vomit, it's going to come out of their mouth and not go into their lungs. Don't put anything in their mouth. Time and observe. Don't hold them down. You can cause extreme bruising. You can dislocate joints. You can break bones by trying to restrain them while they're jerking. You cannot stop the jerking. Put something between the jerking limbs and hard objects, or remove the hard objects if you can. Follow their seizure action plan, and once it ends, make sure that they are left with a responsible adult. If it goes on for longer than 5 minutes, you're going to follow whatever your school action plan is and get help. You have the first aid in a wheelchair? Yes.
On those videos that were shown there, I noticed 2 or 3 of them people, they would bring their hands back away from the person that was having the seizure and use their elbows. Was that to prevent bruising and such?
They were propping the person up behind them so that they didn't fall backwards. They propped them from behind, which is a good thing to do so that they'll stay on their side and so that the liquid's in their mouth.
But in several instances, I noticed they went to the full forearm instead of using their hands.
Yeah. It's just a way of protecting them without grabbing them. You want to leave a kid in a wheelchair in the wheelchair if you can. Often the families will have padded the wheelchair so that the seizure action doesn't cause them to jerk into the metal of the wheelchair. You want to support and protect their head and protect their airway as much as possible. Follow that student's seizure action plan. Status epilepticus is 30 minutes or more of a seizure. It is a seizure emergency because the neurons, if they remain in a seizure state for 30 minutes or more, there are chemical changes that occur inside the neurons that can cause neuron death. They need treatment before they reach the 30-minute mark, which is why we say to call for help after 5 minutes. It allows time for help to get to you, for them to start administering the emergency medications, and for them to transport the student to the emergency room for medical care. Status can also be repeated seizures. They may start to come out of the seizure and then go into another one. 3 or more seizures in an hour. You need to get the student to help. This was in the film. A seizure emergency. Any first-time seizure, if you don't know the student has epilepsy, treat it as an emergency because there are so many really awful reasons why they might be having a seizure. You need to get them help. Any convulsive seizure lasting longer than 5 minutes, repeated seizures, 3 or more seizures in an hour, more seizures than usual, or a change in the type of seizure. If it's an unusual seizure for that student, get help immediately. If the student has injured themselves as the seizure happened, if they have a head injury, if they've swallowed water into their lungs, if they have diabetes, if they're pregnant, they need help. A pregnant student having a seizure, the fetus can be deprived of oxygen. They need help immediately so that the fetus does not suffer. If you're on a field trip and you don't know how far away you are from medical help, you may want to call for help immediately as the seizure begins because you don't know how long it's going to take help to get there. So what can trigger the seizure? Most of the time in students, they didn't take their medicine properly or they forgot it. Stress or anxiety, test time. If they didn't sleep well. Missed meals. Why is that?
Blood sugar.
Blood sugar. Insulin promotes seizure activity. When they have an abundance of insulin that doesn't have any sugar to link up with, they're going to be more likely to have seizures. In fact, one of the treatments for epilepsy is a low glycemic index diet in addition to medication. Because if you can keep your insulin level steady, you are less likely to have a seizure. So having a Mountain Dew for breakfast, not a good choice in a kid with epilepsy. Even Pop-Tarts, not a good choice. They do well if they eat some protein for breakfast, a high-protein cereal, an egg, a protein drink, a protein bar. Eating carbohydrates and sugar without protein is going to set them up for having seizures mid-morning. Having constipation or a full bladder in some students will cause them to have breakthrough seizures. There are antibiotics that lower the seizure threshold, and there are some antibiotics that interact with the seizure medication. So if the kid has an infection and the doctor is treating the kid with antibiotics, they may be more likely to have breakthrough seizures. Menstruation. Estrogen is a seizure promoter. Depending on where the girl is in her cycle, she will be more or less likely to have seizures. When the estrogen is high and the progesterone is low, they're more likely to have seizures. Progesterone protects against seizures. Estrogen promotes seizures. Flashing lights in about 1 to 3% of people with epilepsy, flashing lights can trigger a seizure. And this includes if you're driving, if a train goes by between the sun and the bus, if you're driving by a fence or a wall where the sun is going through and flashing, that can cause a seizure. But it's only 1 to 3% of people with epilepsy. Hyperventilation. My son participated in a Boy Scout rain gutter regatta. Does anybody know what that is? No. You make your little wooden ship and you blow it down a rain gutter and you have races. And his Cub Scout troop was doing this. They'd made their ships. They were blowing them down the rain gutters. And I saw one of his fellow Cub Scouts have a partial seizure from blowing his boat down that rain gutter. And hyperventilation, that's one of the things they try to get the kids to do when they're doing the EEG. They have them breathe really fast or breathe into a paper bag, and they try to get them to hyperventilate to provoke a seizure. Being overheated or overexertion can cause seizures to break through. You mentioned the salt. Being overheated can cause imbalances in the sodium and the salt levels in your body. So I've emphasized already, seizure observation is very important. It helps the physician to get the kid under control. And if they can get control of their seizures, they have a chance of outgrowing them. So observation can be really helpful to the family. And you can identify things that trigger the seizure, you can identify seizure patterns, and you can identify precautions that the student should take. There's the observation form from the Epilepsy Foundation. They are available on the web from the Epilepsy Foundation's website. Treatment. Lifestyle changes can help. Caffeine in some people promotes seizure activity. They do well to avoid caffeine. Eating a regular diet, evenly spaced meals which have some sort of protein content that are not high carb, not high sugar. Eating slower digesting carbohydrates, sweet potatoes instead of white potatoes, whole grain rice instead of white rice. That can be helpful in keeping the insulin levels from rising. Getting enough sleep, having a regular schedule, avoiding stress, using stress reduction techniques. My daughter has used Tai Chi and yoga. And there are some deep breathing exercises that some epilepsy patients have told me about that work for them. Avoiding whatever it is that is their particular trigger. And there are different things that trigger different people. Some people, a musical tone, seeing a certain color can be their trigger. There's some really weird stuff out there that can trigger the people. It's because of where in the brain their seizures are coming from. Medication is the main thing that's used to treat epilepsy, and about 70% of epilepsy patients get complete control with medication. About half of them get control with one medication. The additional 20% are using 2 or more medications. All epilepsy medications have side effects, however. Side effects, they can interfere with sleep. They can make you very sleepy or have difficulty falling asleep or difficulty staying asleep. Your appetite. There are epilepsy medications that cause them to never feel like they're full. And they can gain 40 pounds in a matter of 1 or 2 months because they eat constantly. They never have that sensation of having had enough. There are epilepsy drugs that are used as diet drugs. Topamax came out as part of a diet drug just a year ago. Behavior problems, especially in kids. There are a couple of the epilepsy medications that are well known to cause aggression, hyperactivity, and can create real behavior problems. Many of the epilepsy medications cause fatigue, dizziness, and blurred vision. They are slowing down the brain to stop the seizures, and they slow everything down. Epilepsy patients can be forgetful because of their medication. They can have memory recall problems and word recall problems. Dangerous side effects, liver, blood, and there is a rash that is the sign of a complete and total body reaction to the medication, which is very dangerous. There's a mild example. You can find much more horrific examples on the internet, on Google Images. This rash, if you see a kid who's being treated for epilepsy with a rash, they need to see their physician immediately. Because if this condition progresses, it is life-threatening. The earlier they see their physician, the better. More side effects. Bone loss. Epilepsy patients, the medications bind with calcium. And because of that, they can have bone loss. My daughter has less bone mass than I do. She's in her 30s, I'm in my 60s. Dental, gum overgrowth. They need extra special dental care. Leg cramps because of lack of potassium. Skin, they can have acne, rashes, or brown spots because of the drugs. Hair. One of the medications causes hair to break off and fall out, and another one of them causes hair to grow as sideburns on the body. They are very hairy. They try not to use that particular medication in young girls because it masculinizes them. And looking back to my high school classmates, there was a girl who sat next to me in homeroom, and I'm pretty darn sure she took that medication because of the way her face looked and the way she had hair. Some antibiotics decrease the effectiveness of epilepsy medications. Vagus nerve stimulator. Here are plastic examples. Yeah, it is. It's a pacemaker for the brain. It does look like a pacemaker, and it's inserted like in the chest, like a pacemaker. This is an adult-sized one. This is a kid-sized one. The only difference is the size of the battery. The kid-sized one won't last as long. They are inserted in the left chest, underneath the collarbone, right here. Occasionally, they will be inserted in the left armpit. They are always on the left side, always left side. It periodically fires. Yes?
My nephew is getting that put in next week. How effective is that? He has severe seizures.
Her nephew's getting one put in next week. How effective are they? They are effective, and they tend to work better the longer you use them. It takes a while for them to become totally effective because the doctor has to program it there's 5 variables that the doctor controls. There is the strength of the charge, how long it charges for, how long it goes off for, how long between the charges, and there's a couple other electrical things that the doctor controls. You cannot start at a very high level because the side effects will be too disturbing to the patient. So you have to start out very low and kind of ramp it up. It takes a month or 2 to get it, and maybe even 3 to get it ramped up. It depends on how well the patient puts up with the side effects. Okay? It goes off on its own periodically. It will fire. It starts its cycle by firing at whatever strength the doctor has set it for. Then it goes off, and there's a rest period between the firings, and then it fires again. And those periodic firings kind of reset the brain, and they can stop seizure activity in progress. So, if you want to stop a seizure, you know, the kid is having a seizure, it started, you want to make sure that the device goes off to stop the seizure, you are given a magnet. And this is not a real magnet, this is just a facsimile because I can't carry the real thing around with me. It's too strong of a magnet, it can damage my electrical equipment. You swipe it from the center of the chest going out towards the shoulder. That makes it start its cycle and have an emergency discharge of the electricity, which can stop a seizure in progress. Now, you do not want to hold the magnet over the device because that will turn it off. They make it able to turn off like that because if a patient is doing public speaking, like I am today, or wants to sing in the church choir, for whatever reason, if they need to turn it off, they use surgical tape and tape the magnet on top of it. That turns it off. So you don't want to hold it there. That is not first aid. That's going to turn it off. You can swipe it multiple times. You need to wait a minute between to make sure that it's not worked already. You can swipe it again. They warn you not to swipe it continuously for 4 minutes, but that would be pretty extreme. You should be getting help for the kid before that happens anyway. The rep told me he had a woman who smoked, a smoker, and she was going into her doctor, and when they go into their doctor, the doctor hooks up to it. You can see down here in the lower corner, the doctor is programming it and getting a download from the device, which tells him how many times it went off, how long it went off for, what it's doing. This woman was setting her device off a lot. And the doctor is like, what are you doing? Are you having that many seizures? What's going on? She was a smoker, and she wore the magnet on a wristband. Every time she took a drag of her cigarette, she was setting the device off. She was okay, but the battery needed to be replaced much, much sooner because she was wearing out her battery. And it's a $10,000, $15,000 surgery. So it's not a small thing. So there's the first aid. You swipe from the middle of the chest out to the shoulder and wait 1 minute before you swipe again. And you can see there's a video. I've given you links for a video where you can watch how to use the device and learn more about it. You might want to check out the website since you're going to have someone in the family getting the device. What are the difficulties? Why can't they ramp it up quickly? Well, the device is implanted, the wire goes from the battery and it goes up to the vagus nerve and it attaches. There's a spring. The surgeon pulls the clamp out and it clamps onto the vagus nerve. It discharges right next to your voice box and your throat. It can cause coughing, hoarseness, voice changes, shortness of breath, throat pain, and it can even cause vomiting in some patients who have a really strong gag reflex. Okay? So that's why you can't ramp it up quickly. You have to go slowly. It has to be programmed and reprogrammed. That requires a lot of trips to the physician. And when the battery runs out, it has to be replaced surgically. This part on the vagus nerve is very difficult to take out. It can be done by a really, really good surgeon if there's not too much scar tissue around it. However, a lot of people, if the device has too many side effects for them, they will have the battery part removed and leave the leads on the vagus nerve end because they're just too hard to get out. That requires special shielding when they do MRIs. So you don't undertake it lightly. You want to really have a severe seizure condition. It can also help with depression, and it does tend to, as the longer they use it, the better it works. Rescue medications. Diastat. Now, I'm told you can't do this, but you need to know what it is. If the student has prolonged seizures that are life-threatening to that student, the doctor will often prescribe a rectal Valium gel, which comes in this container. This will stop the seizure. But it's also embarrassing to the student. You don't want the other students looking on when it happens. You have to pull their pants down, stick it in their butt. And they can have diarrhea afterwards, all of which is extremely and incredibly embarrassing. They are now coming out with drops and pills that can be put in the cheek and massaged into the gum. And this year, or at the beginning of next year, we expect the FDA to approve a nasal spray, which has the same type of drug that will stop seizures that are life-threatening. This is an example of the seizure action plan. If your school, I encourage your school system to use some sort of seizure action plan, seizure observation. The forms are available from the Epilepsy Foundation, free downloads, and they are Word documents that can be modified to suit your school district. They're individualized, they're prepared by the family with input from the school nurse and the physician, and they are really important for that student to receive the proper care. We do education for students. We have a program for elementary age students, middle school students, and high school students. These programs really help with bullying. It promotes understanding, and it teaches the kids the proper first aid. That gives them the power to deal with the seizures and to know that they don't need to be afraid of their classmate who has them. If you see a bullying problem, I encourage you to go to the Epilepsy Foundation and ask that the kids be trained. So, first aid review. Depends on the type of the seizure. Always stay calm. Remember, most of them are not medical emergencies. Time it, nothing in the mouth, and don't hold down, don't restrain. I gave you the link for the video. This video can be watched free online. Who has epilepsy? Supreme Court Justice John Roberts has epilepsy. My daughter Elizabeth, who is a physician in North Carolina, has epilepsy. And Tony Coelho, who was a legislator, has epilepsy due to a head injury when he was a child. We think my daughter's epilepsy is genetic. Turns out my mother-in-law had epilepsy her entire life and never knew it until she was in her 70s. It took us talking about our daughter's partial seizures before my mother-in-law realized that these funny things that had happened to her were epilepsy. Here's some resources for you. There's lots of wonderful resources online. Here's some famous people. Anybody know somebody up there?
Sir Isaac Newton.
Sir Isaac Newton, yes. Leonardo da Vinci. Handel. Anybody know this guy? Napoleon, yes. A writer. Charles Dickens. Another writer. Edgar Allan Poe. Another writer. Dostoevsky. By the way, writers, people who have complex partial seizures are often hypergraphic. They like to write. Very interesting. Thomas Edison, Alfred Nobel, the Nobel Prizes, the inventor of TNT, had epilepsy. Okay, here's some more recent ones. Agatha Christie, Bud Abbott, Truman Capote, Richard Burton, Florence Griffith Joyner. She had a small tumor and she actually died from sudden unexpected death and epilepsy. Very tragic. Chief Justice John Roberts, Alan Fonseca. By the way, there's a ton of football players who have epilepsy, head injury. And the NFL is a huge funder of research into head injury and epilepsy.
So is the state of Nebraska.
Margot Hemingway, Danny Glover, and Prince. Prince outgrew his epilepsy. He's one of that 70% of kids who was able to outgrow his epilepsy. So let's get these kids diagnosed and treated. We want them to outgrow it. Thank you. Any more questions? Question?
On a school bus, please. We were instructed, not to hold or restrain a kid who is having a seizure. A school bus is such a confined space. What would you recommend we try to do if we had a seizure on? I'm thinking of the seating with a lot of legs and braces and things.
Yeah, you're exactly right. You don't have a lot of space on the school buses, and there's a lot of metal objects that are hard. You want to put something between the student and the hard objects. You want to lay them down either on the seat or on the floor of the bus. Have the kids away, the other kids away as much as possible, because if they're all crowding around, it's harder for you to do what you need to do. You do the best you can to keep them from injuring themselves. Use jackets, backpacks, whatever you can to keep them from hitting against those hard objects. And you do want to keep them on their side.
In the wheelchair buses, there's open spaces in the back more. Is it a right to slide them to the back of the bus to move them to a more open space?
If you can do it without injuring them, you can move them if you can do it without injuring them or injuring yourself. You want to stay away from their mouth because sometimes the teeth are clamping down and you don't want to get your hands or anything near their mouth because you can get bitten. They may bite their tongue, by the way, and there may be blood coming out of the mouth. It is easier to heal a bitten tongue than it is to heal broken teeth, dislocated jaws. So, yes, they may bite their tongue, but it'll heal. Yes?
Does it matter which side they're on?
Does it matter which side you turn them on? No, it does not.
I have a big bus, so we usually don't have anything on, and I have dealt with seizures, so I always carry a blanket.
She says she has a big bus, and she has dealt with seizures on it. She says she carries a blanket. It's a very good idea. I know people with epilepsy who keep blankets and pillows in their office or in the classroom to deal with the seizure. So carrying a blanket on the bus is a great idea.
If they don't have seizures on a constant basis, but they haven't been diagnosed with, would an MRI show?
Great question. Will an MRI show anything? A lot of people with epilepsy have normal MRIs because the damage or whatever it is that's wrong is so small that the MRI technology cannot pick it up. Or if it's a sodium and calcium ion problem, that's not going to show up on an MRI. So my daughter's MRIs were all normal. Having a normal MRI is actually a good sign for a person with epilepsy because they are more likely to get control of their seizures, and it means that there is no other underlying brain problem. It is a huge concern in the elderly, and when I do presentations to general audiences, I actually have a slide with a graph that shows the incidence of epilepsy when it's diagnosed, and after the age of 65 or 70, the incidence of epilepsy is almost a straight line going up. If you are fortunate enough to live into your 80s or 90s, the likelihood of your developing epilepsy becomes much higher, much greater. And our senior citizens are having epilepsy that is going undiagnosed. I know this in my own family. My father's younger sister started having seizures, which were like colored lights, and losing periods of time. And she told me, I think it's my blood pressure medicine, I think it's blood pressure. She ignored it for 3 years, and I said, Aunt Dot, I think you need to tell your doctor. And she did, and the doctor ignored it too. And I have to tell you that she died of a brain tumor because her symptoms were ignored. And it's extremely common in the elderly, and it's extremely often misdiagnosed. It's a huge concern of the Epilepsy Foundation as a whole, and I would encourage you to insist that your mother get an EEG. Now, there's a problem with the EEG. If you don't have a seizure, nowadays with managed care, the EEG, they give you 45 minutes if you're lucky. And if you don't have seizure activity in those 45 minutes, you can have a normal EEG, and you can detach from the EEG machine, walk out in the hallway, and have a seizure in the hallway, and your EEG was normal. My daughter's first 2 EEGs were normal. So a normal EEG, we have 24-hour monitoring in the hospital, which is more likely to pick up a seizure, and then they'll do things to the patient. They'll scare the patient, they'll have them drink Mountain Dew. There's all kinds of stuff they do when you're in the hospital and they're trying to provoke a seizure. They also have ambulatory EEG, which the patient wears as a backpack or a waist pack, and they can do it over a 3 or 4 day period in the home. And you basically live in your living room, you sleep on the couch, and they have a camera trained on you, and you have a little device, a button that you push. And if you think if you're with her or she thinks that something's happening to her, she'll push the button and it'll mark on the EEG tape. So, and if you want, you can talk to me more about what she could do. But it's an extremely huge problem for the elderly and a big concern. Yes?
Did your daughter grow out of her seizures?
Good question. Yes, but she is extremely careful. She never takes being seizure-free for granted. She eats very regular meals. She does do Tai Chi and yoga. There's a lot of stress to going through medical training and residency, and a lot of loss of sleep. She is extremely careful about those things in her life that she can control. And I am extremely concerned that when she's talking now about giving us grandchildren, and that thought really concerns me because during pregnancy you can have those estrogen surges. And we know for a fact that her seizures were estrogen sensitive, and they lined up with those times in her menstrual cycle when her estrogen was high. So she is seizure-free now. She is off medication. However, we don't take it for granted.
I just want to make the comment that my nephew's had seizures for years. He just graduated this past year. And all this time, we've always heard seizures this and seizures that. And I was stunned today to realize that he has epilepsy. Epilepsy has never been...
Her comment, her nephew has had seizures for years and years and years. He just graduated from high school, most of his childhood. And she had never heard the term epilepsy used. They always called it a seizure disorder. And yes, actually, I have attended the American Epilepsy Society's annual meeting, and the doctors who specialize in treating epilepsy are kind of up in arms that their colleagues will not use the term epilepsy. They insist on this euphemism, seizure disorder. It confuses the patient. It keeps them from getting the help that they need. And we all need to kind of get over epilepsy being this horrible, stigmatizing term. Now, I don't like the word epileptic. And I do not use the word epileptic. I will say person with epilepsy, because the term epileptic to me sounds defective, and I can't bring myself to use it. Anybody else? I appreciate your attention.